Hello, this is Anne DeGheest from the Anne Insights channel on YouTube. Welcome. This is December the 4th, 2020. Today we have two videos we're going to discuss. The first one, we're going to discuss how COVID is going through the roof in the US, and we're breaking all the records. So you don't want to miss this part. And how Europe is bending the curve and is going to be reopening for the Christmas holiday a little bit more. While in the US, we're going more into more controlled situation there. In the part two, we're going to do a review of what we know and what we don't know about the vaccine and how you can avoid being infected. We're going to go a deep dive on the vaccination. When could you expect to be vaccination? What vaccine? What are some of the limitations? And we'll do a quick treatment update. So if you remembered, I'm not a doctor. I'm just have a lot of experience in healthcare. My description of my background is on the YouTube description of each video. And I'm like a Reader Digest. I am trying to summarize the information in a way that you can take better decision. And please help me transfer the knowledge and post this on social media. Thank you, and let's get the show going. Hello, this is Anne. This is my second video on December the 4th, and we're going to be focusing on the clinical insights. And please take a look at my first video that's posted on YouTube, where we see that we basically went through the roof in the US and broke all the records. And that's the equivalent of losing a 9/11 number of deaths, which is around 2,900 people per day. Today, we're going to review what we know and what we don't know. I thought it'd be kind of nice to kind of go back to say, how can you avoid being infected? What do we know about the disease? We're going to do a deep dive on vaccination. What does it mean? When can you get vaccinated? What are the issues in the logistics? And I will do a quick treatment update and more data again on vitamin D. If you haven't heard me yet, take vitamin D. There's more data has just come out. So what do we know? And what still we don't know? What we know about the vaccine is that the mRNA, which is done by Moderna and Pfizer, have over 94% efficacy, but for adults, and I want to emphasize that, none of those vaccines have been tested on children. It takes 2 doses at 28 days, and you have to wait for the second dose to be able to build a robust antibody response. The UK has approved Pfizer on December the 2nd. The US is reviewing those two drugs. We also know that the antibodies response have been higher than people who survived COVID, so that's really great news. It is also happening for people with the age of 65, which is also what we're looking for. Overall, it's safe after 2 months. 10 to 15% of people get vaccinated get mild symptoms, and it could be enough that you may have to stay at home for 1 or 2 days with a fever and aches. But the good news is that both vaccines show that you have a lower incidence of getting the disease, but also a significantly lower chance of having a severe case of the disease, which is really important. That's the ICU types. There's some confusion about AstraZeneca. AstraZeneca did a manufacturing error in filling up the vial, and some vials for part of the population had only half the amount of the dose for the first injections. And those people had a 90% efficacy, while the rest of the group, I had 2 full injections there, were only at 62%. What's unclear is that subgroup, which is a small group, was a younger population. And so I suspect AstraZeneca is now going back to the FDA and changing some of their protocols to see what happens if they do half a dose and full dose. But I think that one may be delayed. And that's an issue there because AstraZeneca had the biggest capacity in production. That's the one that a lot of the countries had bought billions of doses. The other thing is the CDC will issue vaccination cards. Do not lose them because it's expected that the airlines will ask for this, and even some restaurants and other places will ask for these vaccination cards. So make sure you have a proof of vaccination, and so that's going to be an issue in the logistics. What we don't know. Well, we don't know that you may still get infected and be contagious. Therefore, you still have to wear a mask, even if you have been vaccinated. We don't know. We don't know how long the antibody lasts. Right now, we have 2 months of data. We expect 6 to 12 months, but we don't know. We believe that the memory antibodies and T cells may be more important than the IgG that we've discussed in the past, but they're very hard to test. And the testing that we're doing is a traditional antibody IgG. There's no trial results for children, so we don't expect the children to be vaccinated until probably the end of 2021. And also there's some question is that should we give it to survivors? Well, if somebody is a survivor from March, they probably have lost most of their antibodies. And so these are some questions we still need to ask. Is, what are they at risk of being infected, and where should they be in the rollout of the vaccine? We don't know about the long-term side effect and the safety data. Most of these trials are trying to do a 2-year follow-up. But here's an issue. As soon as these vaccines get approved under the EUA, you have an ethical obligation to offer people in the placebo arm to get access to the vaccine if they had the placebo, because it'd be hard to ask them to wait for 2 years to see if they get sick when there's a vaccine available. So that is going to get an issue in some of those protocols, not only for Moderna and Pfizer to do the 2-year follow-up, but also for the people like J&J who's enrolling people. And if you have a choice of getting vaccinated or having a placebo, what would you do? So some issues there. And then there's the big unknown, which is it will take over $8 billion for the local and state to put together operation to deliver these vaccines, to hire people to deliver that. And it's unclear who's going to pay for that. So there's still a lot of things that are up in the air. So let's do a bit of a deeper dive. This is a BCG, a big consulting firm, who put together some interesting slides. And you can see there's 4 different platforms on how we're developing the vaccines. 4 of them are basically the categories that people are looking at. And we have now 10 vaccines in phase 3 trials, which is great because that means we're going to get a lot of options next year. So to go quickly there, we have this mRNA, which we've talked a lot about from Moderna and Pfizer BioNTech. They work together there. And that's the one that's probably going to be the first one available in the next 6 months. We have another 38 behind them using similar technology. The viral vector is basically the kind of an approach there that Oxford and AstraZeneca is working on, but they have that results problem that's not very clear right now. And that's the same one that the Chinese, the CanSino, is using, and the Russians, which is you take a piece of the vector there and then you create antibodies. And then, of course, the big one is J&J. J&J has a huge capacity of making a lot of doses next year, but they're still enrolling their patients there. So they're probably 3 to 6 months behind. Traditional technologies that you take a piece of the virus and it's activated or it's weakened or it's a sub piece of it. And so in that one, you have Novavax that's coming out in phase 3. We haven't got the results yet, but that's the type of malaria and hepatitis B vaccine that some of you may have had. And then the traditional is taking a piece of the virus that's inactivated. And we probably won't do a weakened part because this virus is so dangerous. And this is like the polio and the TB that some of you may have had. And that's the one that the Chinese are using as an inactivated candidate there. So these are kind of the 4 big buckets there. You look at the pipeline, it's fantastic. I mean, this biotech industry and pharma industry has been absolutely astonishing. They're breaking all the records. Nobody thought they could accomplish this. And I think we need to applaud all the work they have done. I've been on webinars. It's astonishing. The amount of sharing of data across the globe and people helping each other, it's incredible what has been accomplished. So a quick remember on the mRNA, which are the 2 first sets of vaccines are coming on the pipelines, that you look at the spike protein, which is how COVID is attaching to your body. That's the one that basically connect to what's called the ACE2 receptor. And they take a piece of that protein, so it's called the spike protein here, and then you basically make the RNA, you inject it into the body. And the body think, hey, this is something that's foreign, I've never seen it. It creates antibody. And that's the first dose that you get. And the body starts prepping itself to say, this is not something normal there. And in the second dose, this is when most people have the big reaction, is when you truly build a very strong antibody response. It's a technology that has never been used before for vaccine. So we have to see how it's going to scale up. But so far, the results are really, really good. So Moderna, just to remind you, is going to be reviewed. They filed for the EUA and they expect it to be reviewed on December the 17th. The date has been fixed. They've done 30,000 cases. They've now updated their results, which is even better than before. They've had 196 cases, 185 in the control versus 11 in the vaccine. That means you could still be sick. Okay, this is not a cure. This is, it's just lower incidence there. The good news, there was no severe case in the vaccine group. There were some safety data there. People get headache and fatigue and symptoms for a couple of days. So please take the second vaccine. The supply chain is much better for Moderna there. They can just use a normal refrigerator, and that will make the distribution much better. But they're limited in their capacity. It's a brand new company there, and they're expected to make hundreds of millions of doses, or some of the other players are talking billions of doses. What's unknown is how long is the protection, and can you still get infected and become contagious? We still are trying to figure this out. So right now they're talking about 20 million doses worldwide. Since you need 2 doses, that's only 10 million people worldwide. And we'll talk more about what that means. They hope to do 500 million doses next year. And the US government has about 100 million doses, which is around 50 million people for 1.5 billion, but that's going to be delivered over several months. Pfizer has a supply chain problem. They just announced they're cutting by half their manufacturing expectation for at least December. They are the first one that's going to be reviewed probably next week. I think it's on the 10th. Sorry, I have a typo here. They got approved by the UK a few days ago. And the UK is going to deploy 400,000 doses for people over the age of 16. And in their case, they're going to deliver it first to the long-term care residents of skilled nursing facility as opposed to the healthcare worker. I really missed up that one. This is the thing that we worry, is that as they're trying to scale up, you're going to get manufacturing issue. We all have learned that when you do something that's new. And they're having supply chain problem in getting raw materials. And also in their case, they need to control the temperature at minus 70 degrees Celsius. And that means you need super duper freezers there using dry ice. And that's an issue there, because as soon as it gets thawed, you have to use the vaccine within a matter of a couple of days. And so there's a lot of logistics. So what is expected to be done right now is that it's going to be shipped in containers with dry ice. United Airlines got a special permission from the FAA to be able to ship these containers with dry ice. And they're going to get a sensor inside every shipper to keep track of the temperature, because if the temperature gets elevated for a short period of time, the whole batch could be wasted. So lots of logistics there. Let's look at traditional vaccines. Traditional vaccine, you're familiar with the flu, is that you take a weakened part of the vaccine, you create the antibodies, and that's how you build it. That's what the Chinese are doing. And as a quick, two companies there, Sinovac and Sinopharm, and they're literally giving it to their citizens. And what they're doing is a real world evidence trial with their data there. So we'll see how that works. They're selling it on the black market in China at $30 per shot. You need 2 doses there. The data is not clear cut how well it's working, so we have to keep an eye on that. There was an issue in Brazil where there was a suspension due to adverse events, but they're still doing the analysis there. Russia has a vaccine called Sputnik 5, claiming 91% efficacy. Both China and Russia are selling it to other countries in the world. The big thing, as you know, Russia has this big outbreak, so you kind of wonder the availability of the vaccine or the efficacy, because you can see these are very low numbers. This is only 40 cases, and that's only 91% efficacy. So how do we get herd immunity? Well, the objective is to maybe get herd immunity, and Fauci and other people, Redfield have mentioned, maybe by Labor Day or September 2021. And that's because, we have to do that distribution there. And then I'm going to discuss a little bit more about what's the percent of the population that needs to be covered to get herd immunity. So this was an analysis done by McKinsey, a large consulting firm. And the good news is that the vaccine efficacy of Moderna and Pfizer is very high. It's like around 94, 95%. Now we have to see what happens with AstraZeneca and the other ones, which may be more available in higher quantity there. But if we have very high efficacy, which is over here, you only need around 61, 65% of the population. If the efficacy drop and some of the J&J and AstraZeneca, is lower efficacy, then you can see we need a much higher percent of the population to be covered there. So it's an area to really keep an eye on that, because there's a relationship between the efficacy and the percent of the population we need to get herd immunity. So the other little twist in this is that in the short term, we can only vaccinate the adults in the US, and that's only 76% of the population. That means that we need 60 to 85% of those adults to be covered to stop the spread of the virus until we can get a vaccine for the children there. To give a perspective, if we had a vaccine for everybody at any age, we could probably achieve the herd immunity at 45 to 65% with this type of efficacy there. So I want to give a perspective there. We are going to have to be very careful until probably the end of 2021. So how do we do the distribution? So the CDC has provided some guidance. In the first line of the 40 million doses that's supposed to be available is 20 million people, but that doesn't mean it's the US. It's going to go to 21 million healthcare workers, 3 million residents in long-term care facility, because that's why we had more high mortality rate. Okay. And that was recommended on December the 1st, and people are seeing to implement that. The second in line, and that's going to be probably in February and March, are going to be the 60 million essential workers. These are the teacher, the police, and people doing transportation. The 100 million adults with underlying condition, and this could be diabetes or cardiac. And the 53 million people, there could be a double count there, over the age of 65 years old. And then the rest of the population, so pretty much the younger, healthy adults, less than 65, are going to be in April and June. And this is assuming that manufacturing and supply chain is working. And then the fourth in line are the children, and that's been unknown when that will happen in 2021 because they still have to do the trials. So the other thing you need to keep in mind is that these are just recommendations from the CDC. The ultimate decision maker is at the state and local levels. And so you may have different rules in different states, just to make things fun. I want to reemphasize and manage the expectation that both Moderna and Pfizer have reported 10 to 15% of what's called noticeable side effects. And that means it's like you're having a mild COVID. You're having fever, muscle aches, headaches, especially after the second dose for a couple of days. And there's a concern that people may be afraid to take the second dose. Please take the second dose, because stay in bed, watch Netflix for 2 days, and then you don't have to worry as much about getting this, and encourage your loved ones to make sure that they take the 2 doses. As a result of that, what you're going to see is that people are going to do scattering of the vaccination of healthcare workers, because the last thing we want to do is to give it all to the emergency room department, and suddenly they're all sick for 3 days and there's nobody there. So you're going to see a lot of this staggering, and they're going to do the same thing with the teachers and everybody else. So just give you the heads up about why that's happening. Where will it be provided? At doctor's office in large healthcare systems and in hospitals there. And that may be the easiest way to make sure you get that vaccine cards that it may be needed for at least another year. And in the pharmacies, and that's the question, is on how do you get a card from them. So some logistics there have not been fully worked out. CVS has a big contract to use all the network to provide the vaccine. So to give you a reality check, California has 37 million people, 10% of the US. And remember, I told you there's 40 million promised doses. They just got their allocation. They announced yesterday by Governor Newsom that they got 327,000 doses, which means it's only for 160,000 people in December. So there is the numbers that, they announced at the high level, and then there's the reality of what you really get in the pipeline there. And you can get an update on covid19.ca.gov, and I think every state is probably going to get their own information there. California has decided to have a 3-tier system, very similar to what we have seen. In the first tier is the acute care hospital worker, and in the second tier are the primary care provider workers, because we want to really help people who are taking care of the really sick patients there. We've broken by 6 regions, and to give you an idea, most of the doses are going to be to Los Angeles, which is where we're having that outbreak there. The Bay Area there is, where's my Bay Area? Is the region 2, and we get 80,000 doses. That means it's only 40,000 people. And that's the reality check I was trying to explain. We talk about millions of doses, but look, what's coming in the Bay Area there is only for 40,000 people, and we have many more healthcare workers than that. So it's going to take a while. We have to be patient. Then there's all these logistical hurdles there. We need 2 injections, a sub-zero storage. That will require billions of dollars investment. People don't have the money. Where's the money going to come from? And you need at least 2 dry eye machines, because if one goes down, you have to be sure you have a backup. That's $40,000 to $80,000 each. You need to buy liquid carbon dioxide so you can make the dry eyes. This is a picture of dry eyes. You need people to be specially trained to make sure they don't, hurt themselves, on how to manage that. And then what Pfizer is planning to do is to ship with dry eyes, which means the vaccine has to be used within 5 days of when they get it, of when it's being shipped. So you need to have a continuous delivery on a regular basis, like a little Amazon is bringing you a package on a regular basis there. And then we need to put together specialized injection centers. So Germany, for example, is setting up 100 centers where they will inject 30 people per minute for 10 hours per day for 6 months. That's the magnitude of what it takes to vaccinate this population there. So if we use some similar assumption there as in the US, we need to have these massive centers in cities and small cities in the rural area. Asia has a big concern. How do you reach to sparsely populated area there, where people may not be able to travel? So we have to learn all of those issues there. So let's do a bit of a review on COVID, on what we know and what we don't know. What's unique about COVID is a loss of smell and taste. It is, you don't have that with a cold. You don't have that with the flu. If you start losing your smell and taste, you have to assume you have COVID and you need to take appropriate action. We initially thought this was a pulmonary infection. We now have learned this thing is attaching to the ACE2 receptor, which is everywhere in the body. So it's really an immune disease. And that's where we see all these long-term problems that we identified there, where people have damage in their heart, in their lungs, in their brain, the pancreas, in the kidneys. It's triggering diabetes in people who are normally healthy. And this is, I think, what we're going to learn 3 years from now when we look backwards, is that we're all arguing about what the fatality rate is going to be irrelevant. What we're going to be talking about is that we create a new category of chronic diseases, which are the COVID survivors there. And the numbers, it's all over the places, but the CDC is saying that it could be as high as 30% of the survivors, regardless of age and regardless of the severity of the symptoms. A lot of those people, they were mild to medium symptoms. We also know that there's some genomics that can put you in higher risk. For example, blood type A is 1.5x versus type O is 0.6x. So you're more protective of type O. We know that the mutation so far has not increased the fatality rate or has not impacted the way the vaccines are working there. So that's the good news. We also have learned that initially we all worry about surface contamination in all your grocery stores. Now, people say that's not really a big worry. Really, aerosol and droplets is the big problems on how this thing is spreading. Good news, it looks more and more that the antibody lasts over 6 months. Initially, there was a worry about that. And the ICU fatality rate has gone down, but that's when we have plenty of capacity. So we have to see what's going to happen there. What we don't know is that, are the long haulers damage permanent? What we know is people who had the virus in March have problems today, and that's at least 6 months. So I'm going to refer some prior video if you want to do some deep dive. So go back to my August 7 videos there, but pretty much fever is not predictive. You can have the fever there, but 70% of the people admitted into the ER during the March problem in New York had no fever. And so that is not enough. A dry cough is another thing that's pretty characteristic as opposed to the flu and the cold, and extreme fatigues. But really the loss of taste and smell is a big determinant there. So I'm going to spend a bit more time on that. Some data just got published on exactly what happens, what's going on. And 60 to 80% of patients are losing their sense of smell. That doesn't mean it's total, but at least you have a lower sense of smell. And that 10 to 20% I still have that problem after 2 weeks. And this is to give you an idea, is that suddenly French fries will smell like putrid rotting meat. I mean, it's very different. The coffee will be like rubber tires that's being burned. The chocolate, it'll be like a sticky, sweet chemical odor. It's a very, very different taste. It's not just an interpretation. You will know if suddenly it tastes like shit, excuse me the expression. And so this is the interesting thing. ACE2 receptor are not present in the olfactory neuron. So there's another mechanism in how this virus is entering the body. And basically there is what's called sustentacular cells, which is the cells that are into the cavity there. And as soon as it entered the nasal cavity here, you can see this area here. It goes into the nerve cells. And it creates an inflammation response that damages the neurons. And that's what I think is creating the problem. And it basically, that's the technical name is called parosmia. And so it's an indirect mechanism where the neurons are being attacked as opposed to the ACE2 receptors that we've seen in the heart and other part of the body there. And so as you may know, if you've ever heard of neurons, it takes a long time to regenerate them. And so you have to rebuild what's called the axon, which is the connection between the neurons. That's the communication tool. And to make things even more complicated, you have 350 different types of receptors to detect odors. So some people, when they come back and they recover, it doesn't come back the way it used to be. And so you may have a trial and error process there where the body's creating this new, this olfactory bulb, and it's trying to reconnect and doing all of that. And that's why some people have been complaining about. So the brain is trying to basically work in really be repairing that part of the body. The other thing that just came out is that there are small mutation of the virus that seems to be associated with a 2 to 3 times higher risk of developing severe COVID. And if you get exposed to somebody who has that mutation, you may end up with a worse outcome. And so in other words, if you get exposed to somebody who has mild as asymptomatic, there's a high probability you may be mild and asymptomatic. But if you get exposed to somebody who end up with a severe case, you really need to be proactive in protecting yourself. Let's kind of go back on some basics on exposure. We all are going to get exposed. The virus is everywhere. That doesn't mean you get infected. And there's a big difference there. And how do you protect yourself? Well, let's see what we know. 10 to 20% of the infection are coming from super spreading events. That's 10 to 20% of events are super spreading events, and they're driving 85% of the infection. These are the bars, these are the cafe, these are the indoor, poor ventilation, political rallies, sports events. We have learned that the 6-foot distance is not good enough. What you want is really be aware of your environment you're in. If you're in high temperature and high humidity, you're going to be more protected than if it's cold. That's why we're having this outsurge. The prevalence rate, if you're in the prevalence rate with 1% versus 50%, meeting one person versus 50 people will make a huge difference in your chance of being infected there. And this is the key thing, if I cannot say enough. Ventilation is critical. If you're outdoor, basically the virus will be diluted in the air. If you have air conditioning, it recycles the air. And if you have that flu that I was just showing at restaurant in South Korea there, you're going to get exposed even if you're more than 6 feet away. The amount of the viral load is critical. Be aware that your chance of infection is a function of how much you get exposed to. So if anybody is singing loud, talking very, like in Asia now, they want people to speak, softly in the restaurants. That is going to create many more particles by a factor of 5 to 100x. So you want, if people are not wearing masks, just walk out, get out of there. And remember, people are the most contagious when we don't know they are sick. And that's from the time they get infected to 5 days before they start developing symptoms. And some of them are asymptomatic there. And it's no longer 15 minutes and up, it's the cumulative time of being exposed. Remember in South Korea, it was less than 5 minutes because of the airflow. And most people get infected from people they know, family members and coworkers. So it's not the guy running down the street passing it with their dogs. So how do we avoid being infected? People are not getting as concerned about contaminated surface, except for high traffic area like doorknobs and elevators. Outdoor encounters, is pretty safe. Again, let's go back. Your risk goes up depending on how much viral load you get exposed, for how long, and how many times you get exposed to that person there. So again, ventilation, time exposure, really be aware of your environment there. Get a mask, get your distance, and be aware of the ventilation, where the airflow is going. Open your windows if you can. I know it's the winter. If you want to know more, take a look at my November 6th video. Emission, we have learned that the droplets is what basically drops in front. These are the heavy thing that drops in the floor, which means most of the floor will be contaminated if you go to like a store, for example. But the one that really gets us in trouble as this really, really small aerosol of 3 microns and less. This is the magnitude of the size. That's the one that stays in the air. And if it's a cold environment with low humidity, they stay in the air for a long period of time. And that could be for hours and more than 6 feet. And so as a result of that, look at your environment there. This is a British journal paper there, which is if you're in an environment there where there's high occupancy, poor ventilation, and somebody's speaking loudly there, there's a very high chance you're going to get infected there. And so it's not just 6 feet with a mask, just be aware of where you are. And this is to give you an idea. If there's high incidence there and people don't wear masks, then you have a very high probability of getting infected there. Mask, and we spent some time in the video a couple of weeks ago, is that the N95, if you can find them, are the highest one. They have a 95% protection rate. The next level is surgical mask, which you could still get on Amazon. And the next level after that is having 2 to 3 layers that are basically at 45 to 90 degree angle from each other, because what you want is the particle to get trapped in this forest of fibers. So the key thing is that the N95 ventilators, they have these random multiple layers, and that's how the virus gets trapped. Where in the traditional cotton mask, it's made by a machine, so you don't have that as good of a protection there. Again, go back to my video on November 6th that really shows the difference between the type of mask and the type and how you fit it on your face. What you want is to really make sure that you look at the fitting and the type of mask you're wearing depending on the environment you're in. So let's look at the immune system. More and more, we believe that looking at the IgG and the antibody may not be the right markers to look for the protection. It's looking at the T cells and the memory cells. The memory cells is what, when you've been exposed to the flu a year later, you basically your body remembers there. And so I'm not going to go into too much detail, but take a look at the August 14 when we did a deep dive on the whole immune system there. So long-term effect, long haul, I think is what I'm really worried over the long term is going to be the big risk. That's why you really need to protect yourself. It's probably 30% of the survivors are going to get some long-term problems. And we know it's respiratory, and we can see on CT scan that there is fibrosis in the lungs. And we know from SARS in 2003 that those patients 17 years later still have the same damage. So this could be permanent. We know there's brain fog, lots of data showing on data from Imperial College in London on 84,000 patients there that they have loss of cognitive functions. We know on cardiology, there's damage to the heart and abnormal arrhythmias there, and chronic fatigue is the number one cause everybody complains about, in addition to loss of smell that takes a while to recover. So, the data is coming out on a lot of patients there. So there's a very, very big study there showing between 10 to 30% of people have these long-term problems. And a study showed it was up to 98 symptoms. So it is going to be a new category, I think, of chronic diseases. A quick recap, they have shown that there's abnormal arrhythmia and congestive heart failures and inflammation inside the heart that is being done. And it's believed it's, due to it's no longer the virus itself, because by that time the virus is no longer there. It's the inflammation response and the cytokine storm that creates this inflammation that does permanent damage to the heart. Same thing for the lungs. They have shown basically a damage to the airways here, and there's this very, very small virus, as we call it there, that basically clean up, and you can see COVID is all over the places there, and the cilia is what gets damaged. In the brain, they have shown now in imaging that you can see the damage that the virus is doing. And I'm saying this because a lot of people say, people are anxious, they're just, no, these are real things for imaging that shows real damage. And that is the real risk. So just to reassure you, if there's lots of data has come out that if a study on 1,600 patients there, that if they take vitamin D, C, zinc, magnesium, B12, multivitamins, NAC and all of that, it has improved some of the symptoms there. Let's talk about diagnostic. There's a huge pipeline of people who are developing new testing. A lot of them are stuck in the FDA in getting approval there. And so, we all say, where are the testing? People are working on it. They're just not here yet. And I want to spend a bit of time on this. This is very important there. In that time where you get exposed, which is ground zero there, for 5 days, the PCR will give you a false negative. And unfortunately, these are the 5 days where it's the most contagious. And so there's that incubation period, which is why this virus is so nasty there, because that's how it's spreading all that. If you are symptomatic there, you can see that in the gray is the PCR. This is when we start testing the PCR. And this is really a short period of time. It's between 5 days to maybe 10 to 14 days, where the PCR is a reliable diagnostic. If you're positive with PCR, you have the virus. If you're negative with PCR, that doesn't mean you have the virus. And so the rule of thumb is that if you know when you get exposed, don't get yourself tested right away, because you're going to get a false sense of security. The other issue is what's called the antigen. And so as you get exposed to these diseases there, we can start looking at the antibodies. And then unfortunately, some of this testing there in the antigens, are also up to 30% false positive. So the point there is to say, don't assume because you have a negative test that you're off the hood. So really understand where you are in that curve of the problem there. And the antibody test, they peak at 21 days. And so by that time, if you're really sick or not, that's it's more protection for being reinfected there. So this is when the PCR will be positive, and this is when the PS will be negative, and this is where you have a high chance of getting a false negative there. So yes, PCR is accurate, but during a certain window of time. So what that means, another way of saying this is that if you get infected at day zero and you get exposed and you get tested in that first 5 days and you're negative, you may be contaminating other people. And by the time you start developing some symptoms, you have basically, spread the infection there. The CDC has just changed the quarantine from 14 days to 7 to 10 days, minimum of 7, probably 10 days. And but just use common sense. So this is another graphic that shows that depending on where you are, so if you're in an area that has a very low infection rate, like say some part of the Bay Area at 1%, then if you have a PCR, you've probably a low probability that's a false negative. If you're in an area there where there's a high, like let's say closer to the Mexican border there, we have 9 to 10% infection rate there, then you should assume that if you have a negative, you cannot assume you're off the hook. So be aware of your environment you're there, but these are statistics that can tell you, that there's a probability that you may have a false negative. Some good news is that the MMR, which is the mumps vaccines that's developed by Merck, that there is reverse correlation. If you still have that MMR, a lot of us are old enough, we don't have enough antibodies left in protecting you against COVID there. So hopefully people are doing more studies there because that could be a way to really improve the antibodies. So again, I want to go back to say the way we treat people there is that first period of incubation there where the virus is duplicating itself. And then we're having the viral debris. So you may be tested with the PCR, but that doesn't mean you're contagious because this is the area when you're contagious during the viral replication there. This is when you have the debris, you still test positive, but you're no longer contagious there. This is the problem with the disease, is that we're getting this immune dysregulation there. That's why you get the cytokine storm and the dysfunction and all the damage and the blood clots and all the things that creates the long haulers there. So you can see the clinical symptoms are very different. In that first period up to day 11 there, you get these headaches, malaise, it kind of can be confusing there. And then you have to watch your oxygen and get a pulse oximeter at home. If you drop below 93 to 94%, you have to get treatment right away. And then if you unfortunately get into the hospitals there and you cannot keep your oxygen there, then you end up being on oxygen nasal cannula and maybe unfortunately intubations there. So you can see in this area there, we develop antiviral drugs to stop the viral to duplicate itself. And this we try to use anti-inflammatory drugs to stop this inflammation response. So if you look at the drug that's being developed, we have a good news. We have a lot of drugs that are being developed right now, antivirals in that first period of them when you're outpatient. And then the immunomodulators, we know when you start to have the first symptoms and then a combination of all of the above there. So at the high level there's novel therapy, which is a Regeneron that's just got approved. This is the one that President Trump received there as a monoclonal antibody. Basically, it's an injection of antibodies to help you fight the system early when you're in the hospital setting there. And then we're repurposing a lot of therapy. Remdesivir is the other one you may have heard about, which is a bit more controversial about how effective that is there. So the good news, people are continuing to develop new drugs. And vitamin D, another paper, now this 15, that clearly showed that 97% of the people in the ICU that had a vitamin D deficiency as compared to 33% asymptomatic. There's clearly something with a vitamin D deficiency that puts you at significantly higher risk if you get exposed. And there's 12 studies that showed that inverse correlation between the amount of vitamin D you have in your body and the risk of you to get severe COVID. So please take vitamin D. This is another one that just came out. You can really see the correlation. It's pretty clear cut. I've never seen something that's such a nice correlation there. And it looks like, the Black, Hispanic, and whites, it's the same across all the ages and the sex and the ethnicity. So please take your vitamin D. And so I want to finish with that a bit, which is you can do things to boost the immune system. Clearly, vitamin D has a lot of data. Other data have been shown for vitamin C being used in high dose in the ICU, for example, and the vitamin B complex and the zincs. Lactoferrin, a lot of people believe can inhibit the virus entry. So, take that proactively ahead of time. And NAC, is helping you with the oxygen species there when you get exposed. There is some data on omega-3 fatty acid. It's not as clear cut that it could, decrease some of the inflammation response. And the melatonin may prevent the cytokine storm. So if you do get exposed and you think you're at risk, you may want to take some of those supplements. So again, I want to wish you a happy holiday. Stay safe, be creative, do things differently, celebrate with your loved ones, and do some cool stuff at home. And I'll see you in a couple of weeks. Stay safe.